would just say like the main thing is just for these mics at least try to be relatively close-ish to them. Yeah. Cool. Welcome. Go ahead and introduce yourself to the people and maybe tell them a little bit about what you typically see.
Yeah, I'm Brett Goodloe. So I'm a sports medicine surgeon at VCU Health here in Richmond. I've been here. I'm in my second year of practice here, and it's been awesome being back in Richmond. My wife's family's from here, so it was kind of a natural move for us. But yeah, I specialize in sports medicine, so I take care of hip, shoulder, elbow, knee. It's kind of elbow season right now with baseball. Yeah. It's a bit of an epidemic, but shoulder, hip, and knee. I do mostly arthroscopy-based procedures, and any athlete that has any sort of injury, they're always welcome in my door. So
cool, I love it. Yeah, we were talking a bit about elbows before, so why don't we just jump into that? Sure. We see a lot of middle school athletes on the PT side of things that obviously have a slightly different type of injury typically than our physically mature people. What are you typically seeing walking in your door in that like 11 to 13-year-old range, and what do we do about it? How do we change it?
Yeah, I mean, that's a big problem. I fortunately, just the way kind of VCU Health is set up, I'm seeing more high school and college athletes. But, getting to these kids earlier is definitely important. I think the big thing is workload. Yep. And it's a hard thing because, people are trying to specialize in sports early on. I am like big, play as many sports as you can, get as athletic as you can. Yep. Because I just think that impacts you for the future. I think these kids are playing baseball year round, and they're developing arm problems, Most of the time in that setting, it's more of, you're looking at a different sort of pathology, but, I hate seeing that, and I hate hearing that from somebody like you. It's like these young kids are just having elbow problems or shoulder problems. Yeah. I think part of it is that they're not getting the adequate, time off from the sport, truthfully. I mean, the throwing a baseball is a very dynamic and intense process, and it puts a lot of load on your elbow and shoulder, and being able to step away from baseball and play other sports, I mean, that's going to be good for them. That's going to be good for these athletes. So,
yeah, we've got an 8th grader coming in who's like 3 months post-op ACL later today that I'm going to take a look at. It's just crazy to see that stuff that early. So I'm glad you mentioned that workload. And I feel like when I'm whiteboarding with patients and explaining why I think something is happening, like obviously with these kids, we're looking at shoulder range of motion and elbow and all the stuff that we know matters in the literature. But I think that workload, maybe sometimes from doc down, doesn't get talked about enough. And it's like one of our kids who we've already talked about had an injury, and it's like, your chronic workload is not built in March, and we talk about that on a 30-day period, and then how we, leverage acute workload against that. And I feel like that doesn't get talked about much. I mean, how do you, maybe in a simple way, you've got to do things so quickly. Obviously, we're lucky to spend a lot of time with our patients. Like, I don't know, maybe for a high school or a college player, let's use baseball to stick with the theme. Mm-hmm. What is that discussion typically like for you when you talk about workload?
Yeah, I think it's really important. And this is where having those closer relationships with like athletic trainers and then you guys, and talking kind of outside what I see in clinic, but getting to more of what they're doing in season, what they're doing out of season, and understanding that, that really matters. It's interesting. I went to the VCU UVA baseball game this past week, and I did my fellowship at UVA, so I'm close with the athletic trainer there, Brian McGuire. He's fantastic, and we were talking about that. What do those programs look like in the off season? And especially in college baseball, they go from the spring to the summer. Specifically pitchers, but they go from the spring to their competitive summer leagues. And then they're maybe have a couple weeks off, and then they're in their fall sport. And then in the winter, that's really their time to rest. Yep. But the most important season is the spring. Yep. And so some of the coaches, some of the kind of performance-based people, they're still trying to gain velocity during that winter break.
Yep.
And we've seen some injuries during that time because there's still no time where they really let their arm rest, you know, and you can gain velocity other ways and throwing a baseball.
Yep.
I mean, you can still lift hard, you can still work on your core, you can still work on a lot of functional based, metrics to increase strength and increase velocity without putting that stress on your arm.
Yeah.
So that just really has to be built into the program. It's hard because, these kids too, they desire to get better and doing the activity inevitably makes you better. But in baseball, it can be counterproductive.
Yeah.
And baseball specifically is one of those. It's not like basketball, you're missing your free throws. You go practice your free throws.
Yep.
In baseball, you're missing your spots or you're not throwing as hard as you want to. You have to throw.
Yep.
But you also have to have that balance where you are letting your arm rest and you're letting the inflammation go down and things like that. So baseball specifically is a tough sport to kind of manage these.
Yeah, no, that's great. Sticking with baseball for a little bit too, let's maybe switch it to, this is more of your high school, definitely college player where we see it, certainly professionally as well, as like the partial UCL, right? So for people that are interested, ulnar collateral ligament, TJ, Tommy John ligament, and partials, depending on where they're at, different people have different opinions. We've seen some that do well. I'm always scared when I see a partial with a PRP and it's like 6 months later and they haven't thrown a pin yet. It's like, what's going to happen? I don't know, like, what are your thoughts right now about, like, somebody comes in your office, they're 18, they've got a partial UCL tear confirmed, MRI. What do you do about it? And also, how do you include them in the decision-making process?
Yeah, I think that last part that you said is probably most important. So I would argue that probably 80 to 90% of throwers have a partial UCL tear when they come to my door.
Great.
There's very rarely that the ligament is totally ripped apart. I kind of grade them as grade 1, grade 2, grade 3. Grade 1, they're not even coming to see you probably.
Yep.
They probably are just saying that they're a little sore. The grade 2 are what I see most frequently. And then I'd say over the last 6 months, I've probably only seen 3 or 4 fully torn UCLs. I actually did one yesterday. That was fully torn.
Yep.
But the majority of these baseball pitchers are going to have grade 2 injuries. And so those are the partial. And then you got to figure out what's best. And it depends on the position. It depends on the time of the year. Yep. Because the timelines are so important for these kids. You could potentially miss 2 seasons with ulnar collateral ligament surgery. Yep. What I tell people is for UCL repair, I usually predict kind of 8 to 10 months, which is shorter than a UCL reconstruction, but it's still significant. There is some, the guys down in Birmingham are really pushing that expedited recovery with the UCL repair, and a lot of people attach to that because it's very appealing.
Sure.
People are like, oh, I can get back in 6 months. Let's do it. But, every timeline is different. And so I try really hard to get the families and the kids not attached to the timeline,
yes, thank you,
but attached to the rehab process. What our goal is to return without pain. And that's what I went down and visited Dr. Keith Meister down in Texas. And that was his mantra. He wants them to throw without pain.
Yep.
And if you're having pain, then your timeline's going to be different, right? And so I think that's really important to grasp that and to really preach that to these families. But yeah, the partials are tough. I always talk about non-operative treatment with them.
Sure, yeah.
Just because you have a partial tear doesn't mean you need surgery,
yep.
right? And there is some success with rehab. Now, the problem is you're doing a 6 to 8 week ramp up. You're getting into upper body plyometrics, and then you're trying to throw again. And so the athletes see that sometimes as, am I wasting time?
1,000%.
But if you're on the other side of it and it's a win and, you can successfully treat these kids with non-op, I mean, both of us are winning, right? You don't have the risks of surgery, and you get back to throwing at an earlier time. So, it's a tough discussion. I have one on my schedule today that I'm going to have this exact discussion with. And, I think my job is just to kind of deliver information. And, certainly if there's something on the MRI that is persuasive, then I need to let them know that. But if it's kind of in between, I give them information both ways, and then we can make a joint decision.
Yeah, that was going to be my next one is when it comes to the MRI finding, is there for the PTs that may be listening, specific finding with like a partial that you just feel like, I need to let you know this, or maybe not, the outcome might not be as good? I mean, is it being more distal, or I don't know? Yeah,
that's a really good question. So, so the thing we talked about earlier, if there is a distal avulsion with bone attached to the ligament, like you can see that on X-ray. I've talked to Gary Wazlewski about this. He's the Diamondbacks doc for a long time. He said whenever he has treated those athletes non-operatively, they heal. Yep. Just something about that bone being lifted off, that bony response, those bone heals. It's the ligament that doesn't heal quite as reliably. So when there's bone attached to that, I will really strongly recommend non-operative treatment. And it's pretty cool watching the progression of the X-rays as that bone it actually kind of forms like a bullhorn. And that's going to be protective for the athlete. I do think, when there starts to be that mid-substance propagation of the partial tear, whether that's from the proximal segment or the distal segment, I worry about that. Yep. Like there's can be some delamination of the ligament as it goes kind of into the middle section, the mid-substance. I certainly worry about that. I worry when there's a lot of edema kind of around the ligament, so a lot of swelling around the ligament, whether that's proximal or distal. A lot of people ask about PRP injections too. Sure, I am not the biggest seller of PRP. What's your experience been?
Not good.
Yeah.
Yeah, not good.
I think when you look at the data on PRP, it's not, these kids are still, they're doing PRP and then they're still rehabbing.
Yeah. Right.
I think I don't think you're not doing PRP, there's confounding variables in the literature, right? You're still rehabbing. I think the kids that are going to rehab well, they're going to rehab well whether you get PRP or not. And so I'm getting asked the question, like, do I need PRP? I don't think you need PRP. I think if you want to try it, that's fine, but I'm going to shoot you straight on what the literature shows.
Sure.
And I think, just a really good rehab program with a baseball-specific trainer or therapist is what you need.
Yeah, I think not that it changed my mind, but I think it confirmed it when during COVID, Gwathmey did some cool stuff with docs and PTs jumping on Zoom calls, and it was like stem cell actually down here pretty low. I was excited about it, but he wasn't. And then PRP not too far away. And then it was in this case, cortisone injections and just conservative measures. And I've definitely found that, I think especially the harder somebody throws, it just seems like it's more of a reach, I guess.
Yeah. Yeah. I'm actually more, I'm more inclined to do PRP around the shoulder for baseball throwers than I am the elbow. I just, I went in, I kind of dove into the literature regarding it because a lot of people were coming to my office saying, well, what about a PRP injection, right? And there's not a ton out there to support it.
Yeah. Yeah, insurance companies don't love it as well.
No, they don't. It's expensive.
Yeah, expensive. Maybe to switch gears a bit to ACL. I mean, I hate to just talk ACL and UCL is the hot topics, but what are your feelings right now? What are you doing the most of? I mean, are you a primary, bone-to-bone patellar guy pretty much all the time? Any thoughts on quad tendons versus that and where you're at with that?
Yeah, so I use predominantly BTB, patellar tendon grafts. I would say that's probably my go-to in my collegiate athletes. I think quad grafts are excellent. So I trained down in Charleston, South Carolina, with Dr. Harris Sloan, and he does essentially all quad ACLs. And he trained at Emory, and so Emory has been the kind of primary push of the quad ACL, and there's a ton of good literature to support it. Yeah. I think there's risks and benefits of each graft, but I think you can, when done well, I think either one can be totally great for someone trying to get back to sport.
Do you find much of a difference at that 4-week follow-up-ish in terms of somebody being ahead?
Yeah, so I usually see people at 2 weeks and 6 weeks.
Okay.
And I actually think the quad ACL has harder time meeting their metrics in terms of strength after the ACL. I
Yep.
think their recovery is a touch slower than the patellar tendon. What has that been your experience at all?
Yeah, I think so. I talked about this with Ryan, who sees a lot of our ACLs, and he's kind of the ACL man around here. And yeah, I think we feel like probably earlier on, maybe you'll have some anterior knee pain just from the incision graft site with the B2B, but I think they're taking a little bit longer with the quads. We've had a couple people that, and we tend to inherit a lot of people at like 4 to 5 months that have rehabbed elsewhere or whatever. Then they get into like a hybrid training model with us. And we definitely I think we see more people that lag at 6 months when we do LSI testing, like their quad indexes. Yeah, I mean, one of our girls came in, I think she was a quad tendon, but she was like 41% side to side at like 6 months. And it was like, this ain't it.
See, I think I see that a little more frequently with quads than I do BTB. I think up front, you're getting that patellar mobility up front can get pretty stiff, especially on my BTB patients. But I think on the back end, I find that my BTBs are able to regain their quad strength a little quicker than the quads. But it's not, it trails by a little bit, right? Yeah. I think in the end, both grafts are really good and can give you really good results.
Yeah, we said that yesterday. I feel like at 9 months, it pretty much stabilizes. Yeah. We've got another patient coming in, and just quickly curious with the LET, would you consider that as like a primary with, so that's just kind of using the IT band to add some stability. Like, would you ever do a primary for a reason or just with a revision or thoughts?
Yeah. So, absolutely. It's the first answer. I think for my high risk athletes, so athletes who are younger, maybe 12 to 16, play a high risk sport, have some hypermobility, have hyperextension of their knee, especially on the other side. I think I at least have the conversation.
Yep.
Because when you look at some of this emerging data on the LET, I think your re-tear rates are going to be lower. And these are our highest risk population. So I have the conversation with them. But, I also tell them the potential downsides, right? It doesn't come without risks, right? You can have pain on the outside of your knee. I think the recovery up front's a little more challenging.
Yes.
I think they have a little bit more pain up front. It's another skin incision that has to heal, right? You can get hematoma, you can get infection. There's a lot of things that you got to consider. Also, I've had some people that have some irritation on the lateral side of their knee after the procedure, right? That they probably wouldn't have had if we hadn't done the LET. But I think when you look at re-tear rates, I do think it decreases your re-tear rates. And I think there's a lot of data that's showing that right now.
Yep.
And so there has been a heavy push to consider it more for primaries. For every revision, I am doing it.
Cool. Yep.
But there was a stretch where I was really pushing it on some of my primaries. I think I backed off a little bit just because some people are having some discomfort on the outside of their knee. It's another procedure.
Yeah.
And so I think you just have to consider that. But certainly with the re-tear rates, that's such having a re-tear early on for an ACL is just so demoralizing and tough, physically and emotionally. Sure. And so doing things to reduce re-tear rates totally makes sense.
Yeah. Anything you, whether it's you or team there at VCU on the protocol side of things after ACL, like anything that you feel like you're either doing differently or team is doing differently within the process at all in the last couple of years?
So I am, I'm really big on getting the VMO firing.
Yeah.
So this is pre-op too. I think it makes such a difference. Like I push that hard. Arthrogenic muscle inhibition. So it's like this big thing that there's a really well-known surgeon in France that he's put a lot of videos out, put a lot of information out. And one of my buddies went and actually worked with him. And I learned a lot just from listening to kind of what they talked about there. Yep. And, everyone focuses kind of on that pre-op range of motion. Like I want the knee to bend to 100 degrees and then they're like, oh, well, they lack a little bit of extension, but it's probably good. They're bending it pretty fine. But I really think getting the quad to fire normally helps these patients recover well afterwards. Like because you're re-injuring the knee when you go in with surgery. Yep. It's basically just a re-injury, right? The big effusion comes back, all the swelling comes back, and then their quad shuts down again. And I think if you don't address that at the beginning, before surgery and right after surgery, I think you're missing a lot. And actually, I think that leads to the cyclops lesion.
Yep. Yeah.
Because you have that lack of extension, right? And that final extension is really just getting that VMO to contract to lift your heel up.
Yeah.
And so that little bit of flexion contracture, that's where that scar tissue starts to build. And some people can't, get over that.
Yeah, it's like leg extensions for us. I know they were like vilified. And obviously there's a level of early on, you want to protect the graft and stuff. And we've had a couple studies in our literature showing that there's like not that much strain, through the ligament at a certain point. I think before, surgery and after, like we hammer a ton of leg extension stuff in a smart way, hopefully. But I think, it is those of us that do it every day, like it's how we get a ton of quad. And I think just doing closed chain stuff with somebody that's effused and puffy, they don't tolerate it super well. And
they try to work around it too. It's like they start recruiting other muscles.
We can see it. Like it's not, it's not what we want to get. If somebody can't get their quad shaky, like after surgery, the first 4 weeks, it's usually not a very good sign on our end. Yeah, we talk a lot about just like you have to control a fusion before you can fire your quad. There's just no way around it. So,
and I'd be interested for those patients that you're worried about for 4 weeks. Like, did they have that before surgery?
Right.
And you probably, a lot of times you may not see them before, so you don't know, right?
Yep.
And so I would challenge that sometimes they don't have it before, and so just taking the time to let the patient get that VMO firing before surgery, and at least they're learning how to do it.
Totally.
Right? They're getting that biofeedback. They're learning how to do it. And that's even valuable because then they have to repeat that after the surgery.
Yeah, I think too, we find, we typically sit down and whiteboard when we can see people pre-op, even if it's one visit. We love it if somebody is, people come see us. They don't need a referral nowadays with PT, but it's nice, I think, for us when surgeons are like, hey, just go, even if you just go see your person one time before, and then we can just really map, and we can get on the table and obviously do what we need to do with range of motion and quad. But I think the expectation piece, because everybody, like we've talked about one athlete recently who's like a monster, but you just don't know. And it's out of your control sometimes in terms of how you feel after surgery. So at least the knowledge and the expectation piece. And, it's like the classic Adrian Peterson example on the back end. It's like, yeah, you're probably not going to be perfect at 9 months. And here's the reasons why. And don't get freaked out. If not. All right, good. Are you good for a few more minutes? Yeah. A couple more things. Cool. Had a couple of staff questions just because we have a mix between performance people and PTs. I think one, it sounds stupid and simple, but is there anything that you really look for when you're just working with other PTs, sending people out? Like, what do you like to see as one or two things that someone's going to do with that relationship?
Yeah. So, big thing for me is communication. And that's one of the reasons that I've been able to work with you so effectively is that, just having the therapist being able to communicate with me, like if a patient's struggling, let me know. If patient's doing great, I like to know that too. You know what I mean?
Yeah.
I got a guy in Fredericksburg right now that is just awesome. He, for my clientele up there, he just communicates with me. He's like, hey, 6 weeks, this patient's doing great, and I appreciate that. Or he'll tell me, hey, they need to work on this and this and this. And then when I have that clinic visit with the patient, I can say, hey, me and your therapist talked. And that just helps so much. Yeah. And it's good for the patient. We're having this kind of collegial conversation going that helps them, so that's big. And then I think where I've had some issues is that the transition from getting their strength and getting their range of motion, but transitioning that into playing a sport.
Yep.
Right. And I think some practices just don't have whether it's the equipment or the facility in order to accommodate that.
Yeah.
But that's a whole nother realm of what these athletes have to go through. And that's probably the most important part. And in that part, it's the mental side of it, right? They're learning how to have confidence in their leg again, or their elbow or their shoulder, So that's why I like, working with kind of these more performance-based practices.
Yeah. No, I think it's fair. again, I guess we're lucky that we're positioned in a place where we happen to do both. So we do inherit a lot of those people, but I 100% like that 3-month mark until 8-9 months is like, you've got to get sketchy in ACL rehab. And like, if you haven't exposed yourself from block to random practice in like a progressively somewhat dangerous environment, I think that's where we fail. Like as PTs, we fail because I think a lot of us out there, and you see it in clinics, we are scared. It's like if you don't have your thrower throwing at 90% at a certain point under your control, and you're just discharging them when they're flipping it with their buddies, and if there's nothing gapping the intermediate, you might feel good about the job that you've done, but really like you've managed the easy conservative stuff. The hard stuff is like, okay, now how do I fill the gap to really get, we expect 90+% of our people to get back. So that's more of a, I don't know, that's a soapbox of our own profession. I think at the end of the day, it is what it is. Like, it's not all, we've got to be better about that stuff.
Yeah. And I think, that transition is just so important. And, when you're dealing with kids where, when I was their age, when I was in high school, that's all I cared about. When I was in high school and college, that's all I wanted to do was throw a baseball, shoot a basketball. That's all I cared about. So like, I get it. But I think sometimes when you're coming back from injury, they just have to have some sort of assistance in that realm, right? Because they've never been there.
Yeah,
most of the time.
What maybe just to kind of round it out, what next 5 to 10 years, whether it's AI stuff, whatever, new techniques, like what's coming down the pike that you are personally excited about in your practice the next few years?
Yeah.
What are you worried about? I don't know.
Yeah, no, I think I'm actually pretty excited about the AI stuff. I mean, that's not really related to kind of surgery or PT, but in terms of workflow, it will certainly help if we can incorporate that with workflow just from the paperwork side of, medicine, which we all fall victim to. But no, I'm just excited to be in Central Virginia and Richmond. I've started to develop a lot of good relationships with people outside of ECU too. Being able to work with you guys, some other performance-based practices. It's just been really fun watching athletes recover and get back to the stuff that they love doing. So that's what I'm probably most excited about.
Cool, I love it. Well, appreciate the time. Everybody can follow along, follow you on, I don't know, I guess social. I guess all your stuff is personal.
I got X. I got J. Brett Goodloe.
There you go.
Go ahead.
All of these listeners. All right, man. We appreciate it. Are you rolling with Scotty on the pick this week?
Yeah, I think so.
All right, I got Bryson, Scotty. So we'll see. All right.
Keep the hot hand.
That's right. Keep the hot hand. All right, man. Get out of here. Appreciate it.
All right. See ya.